Thank you. Welcome to the second session of this management of colonic neoplasia. Um, I'm honored and privileged to moderate this course with the Professor Douglas Rex. And we have exceptional speakers who's the world leader and forefront of management of colorectal neoplasia and who's making the world standard of the standard of care. It is very interesting to hear their take on the ESD from in different healthcare environment. And this is going to be really interesting session, and hopefully we can make a good discussion out of it. To begin with, I would like to start with the introduction of Professor Douglas Rex. He's world famous Dr. Rex, so not much introduction is needed, but just briefly, he's distinguished professor emeritus at Indiana University, and he has set many of the standard of care for the colorectal neoplasm, the colon cancer prevention, the quality of colonoscopy, and the management of colorectal polyps. And he's a past president of American College of Gastroenterology, and he is the president-elect of American Society for Gastrointestinal Endoscopy. We're privileged to have you, Doug. So please start your talk.
Thanks very much, Norio. It's really great to be here with you and co-moderate this, and I appreciate the opportunity to join this great session. I have to give a little bit of a disclaimer because I'm very much of a novice at doing ESD, but I have settled into an interest in rectal ESD, so the title fits well. And if you could go ahead and start the recorded presentation, thank you. Hi, everybody. This is Doug Rex from the U.S. Thank you so much for inviting me to speak at the meeting. It's a tremendous honor to speak at this meeting. I've got a huge amount of respect for my Japanese colleagues and their enormous contributions to endoscopy. So this is the title of my talk. I have to admit that when Professor Inoue initially asked me to speak, I didn't know this would be the title, or I might have declined because of lack of expertise on my part with regard to ESD, but I ultimately thought that it was fair for me to give this a shot for reasons that I will explain. These are my disclosures. When I looked at the title and the titles of the other talks, I kind of came to the translation that I think what the title is suggesting is that in the United States, we might consider that ESD on rectal lesions is the minimum amount of colorectal ESD that we should be doing, that perhaps we might come to the conclusion we don't need to do it in the colon. And I think that that's probably a pretty fair perspective, but I want to strike a couple of cautionary notes. The first one is that I'm not an expert in ESD. This is the first ESD specimen that I produced. It's from a rectal lesion. I did my first ESD earlier this year, so I'm very much of a novice. On the other hand, there are a number of people in the US who are very good experts at ESD, including my co-moderator, Norio Fukami. And Norio has always had what I have viewed as a very sensible approach when I've heard him speak and write about ESD. However, there is a very large range of approaches and attitude among US experts. There are experts on this list who do ESD throughout the colon, and they do it on lesions that I consider to have an extremely low risk of cancer, even serrated lesions in the colon that have no worrisome endoscopic features they may remove by ESD. So I just want to point out that although I think I can explain why rectal ESD may be the way that we should be starting or focusing I can't say that my opinions represent everybody who's doing this in the US by any means. So we would get many different answers depending on who we ask about this question. I may not be the best person to discuss ESD, but of course, Japanese doctors don't need anyone to explain ESD to them. I think I may be able to explain why ESD use is limited in the US and why rectal ESD is, at least for some lesions, is a good place for us to be starting, and a place where perhaps we should consider this is the minimum in ESD that we should be doing. So part of the reason that there are very few enthusiastic ESD practitioners in the US and why it's maybe hard for Japanese doctors to understand why we lack enthusiasm are demonstrated on this slide. So this is my understanding about ESD in Japan, and correct me please if I'm wrong. So first of all, doctors in Japan are paid for the use of electronic chromoendoscopy. The payment for EMR is about twice that of standard colonoscopy. For ESD is about 5 times that. It's common in Japan to perform an initial colonoscopy to examine the lesion and plan the resection. Hospitalization is not as expensive as it is in the US and is commonly used after the procedure, and the medical legal climate is quite good. If you compare the situation in the US, we get no payment for any form of imaged enhanced endoscopy. There's a small incremental payment for EMR. We don't have a code for ESD. We hope to have one in 2 or 3 years, but right now we have to use what are called unlisted codes, which get variable payment. Most patients expect when they go to a referral center to have the lesion removed in the first session. You have to do a lot of explaining beforehand for people to understand why you would do an endoscopy for planning. You have to get good referral notes and pictures. If you feel like you need to hospitalize the patient after the procedure, it's very expensive and consequently it's discouraged. And the medical legal climate is poor and is generally believed to be poor, so that there's a lot of concern about complications. There are a couple of ways to get paid. One is to strike a deal with private insurers, or if you are employed, you can negotiate a work rate, what we call RVUs or relative value units, with your employer, what you think is a reasonable number of RVUs compared to a colonoscopy with EMR or colonoscopy with polypectomy. And if that negotiation is good, then you may feel like you're getting adequately paid. But if you can't do one of those things, you're going to make less money doing colorectal ESD than either EMR or even just routine screening colonoscopies. So there is little financial incentive for most American doctors to get involved. Now, in my experience, if you have a paradigm of practice that involves higher risk for doctors and patients and lower payment, it's going to do poorly. Examples of this that I've been involved in are physician-directed propofol for endoscopy. No reimbursement in the US for this for endoscopists, and there's high or perceived high medical legal risk. Another example is resect and discard for diminutive polyps. Again, we have no reimbursement for imaged enhanced endoscopy, and there's perceived medical legal risk. Add on top of that, many GI doctors own the laboratory where the polyps are processed, or they hire the anesthesiologist, pay them a fee, and bill for the insurance company for their fees and actually make a profit off the services. And these kind of concepts have a hard time going forward. And they have a hard time going forward even though they have a very strong evidence base. There's an evidence base for efficacy, safety, and cost effectiveness of these practices, and you can't make them go forward because they involve higher risk and lower payment to physicians. Now, ESD has a substantial learning curve. Japanese doctors often learn ESD techniques on early gastric cancers. Early gastric cancer in the US is rare. Learning on colorectal cases has a higher risk than learning in the stomach. So if we put all this together, it's not really that surprising that U.S. colonoscopists are unwilling to take time away from their practice to learn a procedure that involves increased risk, perceived medical legal risk, and lower payment than they can get doing screening colonoscopy. Under these circumstances, you have to have a strong and clear medical need to proceed in this setting. So we have to ask, where is the greatest need? And I think we can conclude it's probably in the rectum. Who benefits from ESD? This is really important. One of the advantages of ESD, en bloc resection, which leads to lower recurrence rates, has largely been negated by Michael Burke's studies showing that thermal injury to the normal EMR margin reduces the recurrence rate in the initial randomized trial to 5%. In a study reported at Virtual DDW, it was down in the 1-2% range, the same as ESD. So this advantage of en bloc resection has been negated by this development, probably the most important development in EMR in the past 10 to 15 years. En bloc resection still has the advantage of avoiding surgery in patients who have superficial submucosal invasion of cancer. Now, avoidance of death is rare because the death rate from sleeve resection in the colon is about 0.7%. It's much higher than endoscopic resection, but it's still relatively low. This is a study, a summary of 3 studies from Asia and 3 studies from Europe looking at rates of superficial submucosal invasion in ESD specimens. And you can see it's about 10% in the Asian studies and about 3% in the European studies. This means that in Japan, you do about 10 ESDs for each superficial submucosal invasive cancer that can avoid surgery. In Europe, that, at least initially, that number was around 30 ESDs. Now, this, of course, is the paradigm that we're talking about with piecemeal mucosal resection, endoscopic resection, or EMR. If we get submucosal invasion, we feel the patient needs to go to surgery most of the time. On the other hand, with an en bloc resection and a proper pathology evaluation, that patient could be cured. But again, this is about 1 in 10 patients in Japan and perhaps lower than that in Western countries. By ESD, if all of these lesions were removed by ESD and half of them were superficial, which I think is generous, we'd avoid about 80 deaths. Consider the other problem that we have with surgical deaths, which is surgery for benign polyps. About 300,000 surgeries annually for benign colorectal polyps in the US. Again, if 1 out of every 143 avoids death, if we converted to endoscopic resection, we would avoid 2,100 deaths. That's 26 times the number of people that we could save by doing endoscopic resection for benign polyps compared to if we did ESD for all of the T1 cancers. So I would argue that this is a considerably bigger public health issue than us not doing ESD, especially on colonic lesions. Now, we have other tools for the removal of colorectal lesions, of course, traditional polypectomy. In addition to traditional EMR, we have underwater EMR, we have the full thickness resection device, and for rectal lesions, we have transanal resection. Underwater and the FTRD device are a couple of additional ways that we can achieve en bloc resection for lesions that are in the 20 to 30 millimeter size range for FTRD and up to 35 and maybe even a little bit bigger with underwater EMR. Now, the rectum certainly is special because in addition to the mortality that we avoid when we avoid surgery, we have a significant risk of morbidity associated with rectal resections, at least abdominally performed rectal resections. So when we have a lesion with pseudodepression that's up in the colon, we can remove this lesion by ESD. Here's a non-granular lesion with pseudodepression, certainly has an increased risk of developing cancer. But this lesion is a little over 20 millimeters in size. we might be able to remove it en bloc with underwater EMR, or perhaps with the full thickness resection device. Both of them would be safer than ESD, and both of them are faster to perform than ESD. So they are excellent alternatives for moderate sized lesions. And many of the non-granular pseudodepressed lesions are not that big and potentially can be removed by one of these techniques. On the left, we have the homogeneous granular lesion. On the right, we have a rectal granular lesion with a large nodule in it. This is perhaps the single best candidate for ESD. It is too large to be removed with other endoscopic techniques, and it's in the rectum, where there are the additional advantages of avoiding morbidity and the greater safety of ESD compared to performance in the colon. So a reasonable target, I think, for ESD in the US is rectal LSTs that are 40 millimeters or larger with a significant 1S component, that is a nodule in them. In the recent multi-center trial from Italy, about 1 in 5 of these lesions had cancer in them. Now, we don't know the percentage that had only superficial submucosal cancer with no other aggressive histologic features. If we knew that number, we'd know how many exactly could avoid surgery. But when we do avoid surgery, we avoid the high morbidity of rectal operations. So in conclusion, I think large rectal lesions with a 1S component are a good initial target for ESD in the US. This has the additional advantage of avoiding operations that have high morbidity, and it has the advantage that ESD is safer and easier to perform in the rectum. So I look forward to your comments, and thank you again very much for the opportunity to speak at your meeting.
Sorry, I muted. That was a fantastic discussion. Thank you, Doug. There's several questions come to my mind. First, you mentioned FTRD versus ESD. As you heard from the previous session, the FTRD is limited by size, number one, and much lower other resection rate, which causes residual recurrence. Do you still think this FTRD can be an alternative? And is there any restriction on the size we should set?
Well, I think it's an alternative, again, for size-restricted lesions. You know, I mean, as the company says, we shouldn't probably use it for lesions that are 30 millimeters or more in diameter. Clearly, if the lesion is bulkier, you know, when it's smaller, it's hard to get the entire lesion up in the cap. I do think that there probably are some lesions where we could remove part of the lesion by EMR and remove the remaining part of it that we think is high risk with the FTRD device. And again, I guess the point I was trying to make is that we have some other options besides ESD above the rectum. I think when we go from FTRD or underwater EMR to ESD, it's a significant step up in terms of the skill level, the amount of time that's involved. And so consequently, it's an option. Obviously, if it's a much larger lesion, if it's over 30, 35 millimeters in the case of underwater EMR, it's not going to work. I wanted to say, Norio, I apologize about one of my slides. I realized the narration didn't come through. I was trying to do a calculation on how many lives we would save, you know, by doing ESD on all the T1 cancers. I think there's a little over 20,000 T1 cancers per year in the US. And so I was saying if maybe half of them are superficial, we'd probably save in the range of around 80 lives. But the narration didn't come through. So I'm sorry about that. It was cut off on the slide.
I appreciate your clarification. And also, we're talking about the surgery, and the colorectal surgery is rather straightforward, but it's not benign surgery. The adverse events after the surgery can go up to 15, 16%, even for benign lesions. So I think there's some benefit of a patient not going to surgery because of the uncertainty of clearance of the cancer because of the positive margin, deep margin, if you do the piecemeal resection.
Well, I mean, I agree with you. There's about a 15% readmission rate in the first year after surgical resections. A lot of it is for things like hernia repairs. And so there is an element of morbidity. And I agree with you. It's on that side of the equation. I think it's partly just, all these practical issues that are in play in the U.S. that affect people's thinking about it. And so it's a matter of priorities. I really think that benign lesions going to surgery, as I said, are a much bigger public health problem than the occasional superficial cancer that ends up going to surgery. But your point is well taken. It's not just the mortality. There's also morbidity and cost associated with it.
Great. And I think the reimbursement has come along. In many institutions, I'm getting a fairly good reimbursement with unlisted code. So I think that can be just set aside. Training is just going on, fairly moving forward in the United States. So many many physicians have been trained, and you've been becoming an expert on the ESD. That was great things to hear. So once the training is going well, and we can make the ESD easier and faster with additional traction device, education of physician not to touch it. Some people just trying to mess it up, partial resection, creating scar. That makes the subsequent treatment, even a piecemeal EMR or ESD, make it more difficult. Once you have this really straightforward lesion, ESD can be easier and faster and safer. Then maybe we should just rediscuss what's the lesion supposed to be. Do you agree?
I think that's true. I think it's a little bit challenging. I'd be interested in how you deal with it. I see some people who are learning ESD taking out lesions in the colon that I think are extremely low risk in order to gain familiarity with the technique. Yep. I personally have a problem with that. I don't feel comfortable subjecting a patient that has a lesion that I feel is really low risk to ESD for the purpose of me learning it. I would rather practice on lesions that I think the patient's really going to benefit on. I think that's a challenge in training right now. What are your thoughts about that, Norio?
I totally agree that many people started trying to take the lesion that shouldn't be as a practice for ESD. So we have to really set the standard how you're going to start which lesion. But we have been emphasizing explant model, the in vivo animal model, to just get the familiarity so that they can start with the appropriate lesion. I totally agree with you. Some trainers suggest that hybrid ESD may be the way to go. And initially do the marginal incision and just start doing some dissection and then go to snare. I mean, that can be the first step to learn ESD, but I have a little bit of difficulty accepting that using the lesion as a practice. So
yeah, I saw the recent meta-analysis, which I think was published in Endoscopy, just comparing outcomes with hybrid to standard ESD, and as I recall, the R0 resection rate is significantly lower with the hybrid technique. So I hear what's your message there.
Thank you.
It is clearly an option that can increase the chance of a non-block resection compared to EMR when you think there's a lesion with increased risk.
Well, thank you, Doug. That was excellent. And let's move on to hear other experts.